So today we'll start peritoneum, momentum, mesentery, and intraperitoneal space. So I'm sorry to note, most of you are not coming even 10 minutes after 10. Hmm? Now the count is 114 after waiting for 10 minutes. So you're all supposed to be present at 10 o'clock. So inform all your colleagues who are absent till now to come early. Hmm? Okay, right. So peritoneum, is the peritoneal cavity is the largest cavity in the body, lined by peritoneum, and in surface area, it is second largest after skin. So around 2 meters square. So, as all of you know, peritoneum is divided into both visceral and parietal peritoneum. So, the visceral means covering the internal viscera, whereas parietal means that is the posteriormost layer of the abdominal, anterior-abdominal wall. So, of course, beneath the peritoneum, there are lymphatics and capillaries which aid in absorption, and also they produce exudation also. In a normal individual, there are few ml, hardly 10 to 20 ml of peritoneal fluid will be there, which is pale yellow, viscid, and containing lymphocytes. So why that 20 to 30 ml should be there in the peritoneal cavity is to lubricate the viscera. Why we should lubricate? For easy movement and peristalsis. So that is the reason why there is some peritoneal fluid. On opening abdomen, you will see that there is some fluid. So another character is during expiration, intra-abdominal pressure is reduced and peritoneal fluid aided by capillary attraction travels upward direction towards diaphragm. This is the reason the peritoneal fluid going up, and then there are subphrenic spaces. So it may land there, and if the absorption is defective, it may lead to, in case of peritonitis, subphrenic abscess. So, of course, this is part of just like circulation. This is also circulation of the peritoneal fluid, which is needed because new fluid should come and old one should get absorbed. So it will, during the respiration particularly, the fluid will be going up and then getting absorbed by subdiaphragmatic plexus of lymphatics. And another character is healing is from surface. So that's why large defects heal as rapidly as small. It is not from margin. It is from surface. There will be cells, mesothelial cells will be appearing, and then they will be coalescing to form the peritoneum. That's why any defect is closed in 48 hours. Right? Now, what are the functions of peritoneum? As I already told you, in health, it is mainly for lubrication. Whereas another function is again absorption. So both for lubrication and for absorption. Then Then what about disease in disease? So the other function is pain perception. Particularly, parietal peritoneum will perceive the pain, it can localize the pain. Whereas visceral, very vaguely it is perceived and it may not localize. So another function is inflammatory, of course, this is self-explanatory, whereas immune response is also there. So this is one of the important functions of the peritoneum. And added to that, there is fibrinolytic activity also. So in nutshell, what are all the different functions of the peritoneum? One is lubrication, which is necessary for proper peristalsis. Then absorption of any particulate matter. Then pain perception, inflammatory response, and fibrinolytic activity. So what are all the diseases of the peritoneum? Of course, trauma is there, but we will restrict to first peritonitis, which may be primary, means without any cause. Secondary, commonest variety of peritonitis is secondary to disease of the viscera. Then this peritonitis can lead to abscess, or directly abscess may form after hematoma or something like that. Then another important disease, particularly in medical practice, is ascites, which may be either transudate as in cirrhosis and exudate in other conditions. Then there are tumors, both primary and spread to the peritoneum is commonest. Then adhesions can also form. So mainly it is peritonitis, then ascites. So coming to peritonitis, what are the varieties? It may be either localized or generalized. So usually, let us say there is appendicitis. Usually it is limited to that area. Similarly, cholecystitis, limited to that area, unless they get perforated. Whereas generalized is commonly seen in perforation of duodenal ulcer, like that. Similarly, pancreatitis. Then other type is bacterial and non-bacterial. So bacterial is commonly seen after many diseases of the viscera like perforated duodenal ulcer or appendicitis, whereas non-bacterial, without any cause, without any bacterial, at least in the beginning, as I told you, primary, not primary, this pancreatitis, at least in the beginning, then rupture of bladder, there is no bacteria initially at least. Then there is another, not type, but manifestation, Valentino syndrome. What is this Valentino syndrome? Earlier I discussed when I was talking about duodenal perforation. I talked about Valentino syndrome. Yeah, 6-3. Yeah, It mimics acute appendicitis. What is the reason why? Yeah, 14 also. So the perforated duodenal ulcer can cause pain in the right iliac fossa because around the right paracolic gutter, the exudate will travel and then cause local peritonitis in that area. So it is an important differential diagnosis for acute appendicitis. Then non-bacterial peritonitis is commonly seen because of acute pancreatitis, then intraperitoneal rupture of the bladder and hemoperitoneum also due to trauma. Suppose there is hemoperitoneum, initially at least there is non-bacterial peritonitis. Then what is the reason initially non-bacterial can become bacterial? It is transmural spread of organisms from the bowel that we commonly called as translocation. So from inside the lumen they will come out and then they will be causing diffuse peritonitis. So mainly basically localized, generalized, bacterial, non-bacterial. So what are the causes of peritoneal inflammation? So first thing is bacteria. Bacteria from the GI tract, that is the perforated duodenal ulcer or appendicitis, like that. Then non-GI. What are the reasons for non-GI? Yes, anybody? From where non-GI bacteria can come? Trauma, how can it come? 4, 8 and 6, 3, you both said trauma. How can they come in trauma? What variety of trauma? You are partly correct, but what variety of trauma? Penetrating, isn't it? Yeah, correct. So, but the common root is not trauma. Common root is fallopian tubes. Okay, right. Then chemical. Suppose gastric or duodenal ulcer perforation is there. Acid will leak into the peritoneal cavity. It can cause chemical peritonitis, at least in the beginning. Okay. Then bile. Bile is due to any ruptured or perforated this gallbladder. And sometimes in perforation, not knowing the disease, suppose barium is given, or sometimes by giving barium, particularly barium enema, they may cause perforation of the colon. So this will lead to chemical peritonitis, either acid from the stomach or bile from the biliary tract and barium that is injected. So they can cause chemical peritonitis. Then allergy, starch. Suppose you have opened abdomen with glove, with gloves that is for which plenty of starch is there, then there may be starch peritonitis. Trauma is, of course, not only, as you said, penetrating trauma, even handling of the tissues. If there is rough handling during laparotomy, it will lead to peritonitis. And for your information, post-operative peritonitis is more dangerous than any other variety of peritonitis. There may be ischemia that can also cause peritoneal inflammation, and there is a peculiar disease called as familial Mediterranean fever. These are the causes for peritoneal inflammation. But what you have to remember is bacterial, chemical, traumatic. So these three you have to remember. So what are the ways how peritoneum will get infected? So GI perforation is the commonest cause. So GI perforation mainly due to perforated peptic ulcer, appendicitis, diverticulitis of the colon. So all these ones can perforate, or either by translocation of the bacteria, the peritoneum gets infected. Next, of course, this is the second variety after perforation. Transmural pancreatitis, ischemic bowel, primary bacterial peritonitis. They will be due to this transmural spread of the infection. Okay. Then, as you already pointed out, exogenous trauma, surgery. If you don't follow strict aseptic conditions, then you yourself can produce infection. Then drains. Placing of drains is very important, proper placing. And previously we used to say when in doubt drain, but now when in doubt don't drain. That is the dictum now. So hoping that everything will be all right if you close the abdomen without proper hemostasis. Even if you put a drain, that hemostasis is not going to get controlled. Not hemostasis. This bleeding will not get controlled. So, drain is the one which may function or may not function. So, we should not depend on drains. So, strict hemostasis is very, very important. And the other reason why we put drains is, apart from bleeding, is dead space. So see that there is no dead space. Then there is no need of drainage. Then another variety of exogenous infection is peritoneal dialysis. Okay. Another mode of dialysis apart from hemodialysis is peritoneal dialysis. This is continuous ambulatory peritoneal dialysis followed in many places. It is convenient for the patient. He or she need not come to the hospital once this is arranged. Then females, already I told you, pelvic inflammatory disease and hematogenous. Suppose there is septicemia because of some septic focus in other areas of the body, it can reach the peritoneum. So these are the routes of spread of peritoneum infection. Mainly you have to concentrate on perforation, then transmural spread apart from exogenous females PID and hematogenous. So what is the microbiology? So the bacteria are from GIT mainly, as I already told you. So the number is usually low in upper GI because usually stomach, because of the presence of acid, there is not much of bacteria, except as you know, this that H. pylori, that too in the distal parts. Then of course in the small bowel also the number is not as large as large bowel. So as you go down distal small bowel, from there the bacterial number will increase. So suppose there is duodenal perforation, the bacteria that contaminates are far less than an ileal perforation in enteric fever. Enteric fever, as you know, will be mainly in the distal small bowel, in the terminal ileum. So there the bacteria are more. Then suppose there is obstruction, there is translocation of the bacteria. And if there is hyperperistalsis, there also the bacteria will come out. So then it will increase bacterial count. As I already told you, in biliary and pancreatic diseases, usually they are free unless there is translocation. And usually it is two or more, not single bacteria, two or more varieties. And as already you know, gram negative will produce endotoxin, whereas gram positive, like Clostridium, will produce exotoxin. Already I told you about non-GIT via fallopian tubes. So what are the different organisms? Escherichia coli, streptococci, enterococci, bacteroids, Clostridium and Klebsiella, of which Escherichia is very common, and after some time it is Klebsiella. Usually combination of these two may be there. Then non-GIT, of course, in females, particularly chlamydia, you have to think of. Then other organisms, these are not very common, like Neisseria, Hemolyte. All varieties are possible, fungal, Mycobacterium. In tuberculous peritonitis, you know, is Mycobacterium tuberculosis. So all are possible, but these are common. Then let us go to the varieties. One is localized, another is diffuse, already we have discussed. So what are the reasons for localized peritonitis? I told you already about subphrenic spaces. How many subphrenic spaces are there? Only two. Only two is not correct answer. Same answer you are giving. Another two is not correct, I told you. 7. 6, 3 says there are 7 subphrenic spaces. What are they? You are correct. There are 7 subphrenic spaces, but what are they? That is the question. Yes? Anybody? Okay. Then, so right and left anterior, right and left posterior. So 4. Above liver is not correct. Okay. So you have described 4 spaces. So right anterior, left anterior, right uh, right posterior, left posterior. Then 2 spaces, perinephric spaces are there, isn't it? Perinephric space is there, right? Then, so it has become 6. Any other space? So usually we describe these 6 spaces, and posterior to the liver, not superior to the liver. 7th is posterior to the liver. So these are the 7 spaces that are described, but for our practical understanding it is 4 spaces. So both right and left anterior and right and left posterior spaces, of which the lesser sac is the one that is described as the left posterior space, right? So subphrenic spaces, suppose there is anything that can get localized because it is somewhat closed space. Then pelvis, usually second common cause is pelvic abscess. Then peritoneal cavity itself can be localized to the peritoneal cavity. So this is the greater sac. Of course, already I told you about lesser sac. Then peritoneal cavity itself is divided into 2. One is supracholic, another is infracholic. Supracholic is mainly the subphrenic spaces, whereas infracholic, of course, it contains mainly the intestine, and if the case is delayed from supracholic, there will be overflowing into the infracholic compartment, as is observed in perforation of the duodenal ulcer. In the beginning, it is limited to supracholic compartment, whereas later it will be overflowing into the infracholic, and then the whole peritoneal cavity may get in peritonitis may be setting in. So what are the pathological factors? So these are the anatomical closed spaces are there, like subphrenic and pelvic spaces. Whereas what are the pathological factors? One is this inflammation of the peritoneum will produce flakes. They will be limiting the disease. Then another thing that aids in localization is the intestinal loops themselves will get adhered to one another and also to the peritis, thereby limiting the flow of the pus or exudate. The amount of the thickness of the fluid is also, if it is more turbid, it will not flow easily, and it will also retard the peristalsis. So the disease is localized. And as all of you know, the policeman of the abdominal cavity, it will envelop. And then I have seen cases where perforation itself is sealed by this momentum. And you might have known about appendix being covered and then producing appendicular mass. So thereby localizing the inflammation. So these are the anatomical and these are the pathological factors. So anatomically mainly limited by spaces, and the abdominal cavity itself divided into two by supracholic and infracholic compartments by transcolon and mesocolon. Pathologically, of course, all these things. So the flakes, the adhesions, thick turbid fluid, and the greater momentum. So these factors will lead to localization of the peritonitis. So what are the symptoms and signs of localized peritonitis? Mainly, as I already told you, if it is appendicitis, there may not be any signs of peritonitis except the symptoms of appendicitis, underlying condition. Similarly, gallbladder, cholecystitis, there may not be much symptoms as far as peritoneum is concerned. Underlying disease symptoms are there. But signs will be there of localized peritonitis like guarding, rebound tenderness. Then, of course, subdiaphragmatic abscess can produce shoulder tip pain. Right subdiaphragmatic, right shoulder, left subdiaphragmatic, left shoulder. And if it is in the pelvis, if you do PR and PV, there will be tenderness. So that's how we can diagnose localized peritonitis. Basically, the symptoms will be of that condition that is producing inflammation. Whereas signs are there: guarding, rigidity, tenderness, and others. Whereas diffuse, what are the reasons for diffuse peritonitis? So speed of peritoneal contamination. Suppose there is perforated duodenal ulcer. So there is with force, there is ejection of the fluid. Though initially there is chemical peritonitis in a duodenal perforation because the fluid is pouring out. Particularly, patient if he continues to take fluids, there will be generalized peritonitis. Similarly, in enteric perforation also, unless the patient limits fluids, there will be generalized peritonitis. Stimulation of peristalsis. So, as I told you, if the patient continues to take orally, that's why in appendicitis, actually, there is a mechanism where patient is anorexic after this onset of appendicitis. That is mainly to retard peristalsis. So if peristalsis is stimulated, the fluid will also move as much as possible. Then another thing is, of course, virulence of organism is very important. If the organism is, say, Pseudomonas, even appendicitis can produce generalized peritonitis. So, it is the virulence of the organism. Then young children, problem in young children is the peritoneal cavity is small and spread is easy. Not only that, the momentum is very thin and small, so it is not well developed. So it may not reach the site of inflammation. So then, thereby aiding diffuse peritonitis. Then disruption of localized collections. Already it is getting localized and you have opened the abdomen. Say appendicular mass. That's why we don't operate appendicular mass. Simply because of the fear that we may make it generalized. Sometimes it so happened in those days when there was not much of this imaging, and because of guarding and tenderness we couldn't feel appendicular mass, and after giving spinal anesthesia we have prepared the case for appendectomy, and after giving an spinal anesthesia, because the spinal will paralyze all the local muscles, we could able to palpate the mass. Then we didn't proceed. We have abandoned the surgery, though anesthesia was given because of the fear that we may produce diffuse peritonitis. So, we should not disrupt the already localized collections. Then, deficient natural resistance, particularly those who are immunocompromised, maybe taking this steroids, or might have undergone transplantation. So we are giving immunomodulators, or patient is having diabetes or HIV. So there is deficient natural resistance. So these are the causes for diffuse or generalized peritonitis. So mainly it is the speed, the virulence, children, and deficient natural resistance that will aid in diffuse peritonitis. So what are the symptoms of peritonitis, diffuse peritonitis? In the early phase, there will be abdominal pain worse by moving. So that's why the patient usually lies still. Even breathing can produce increased pain. So that's why there is improper respiration leading to lung complications. So because of the pain only. Then pulse and temperature, already I told you about this. Initially there will be rise in pulse and temperature. Tenderness and guarding will be there. Patient lies still, silent abdomen, peristalsis is hampered. Whereas in the late phases, there will be circulatory failure, cold and clammy extremities. So patient is in septic shock, cold and clammy extremities, sunken eyes, dry tongue, thready and irregular pulse, the so-called Hippocratic facies will be there. There is generalized rigidity, which ultimately will lead to flaccidity because of distension. Distension of abdomen, once it starts, this rigidity will gradually disappear because patient is no longer having enough okay. So all the signs and symptoms of peritonitis are present. So this is the Hippocratic facies. You can see the sunken eyeballs, and the eyeballs are pulled up, semi-open eyes. All these are all signs of Hippocratic phases. So, once again, abdominal pain, worsen movement, respiration, coughing, anorexia, malaise, fever, nausea, vomiting may be there, raised pulse rate, tenderness, guarding, rigidity, rebound tenderness. All these four will be there in diffuse peritonitis. If you do PR or PV, there is tenderness and bowel sounds are absent, still and silent abdomen. Septic shock, of course, will lead to SARS, MARS. So these are the signs and symptoms of diffuse peritonitis. So what are the investigations? Of course, bedside, urine examination is important, ECG also. There is blood examination, CBC complete blood count, what is the blood group, urea, creatinine, amylase to rule out pancreatitis, electrolytes, important because some electrolytes may be lost because of vomiting or because of perforation. So, electrolytes are important. And simple chest X-ray will rule out. It is not abdominal X-ray, you mind it. Chest X-ray is enough for perforation because patient may not be able to, for erect abdomen, you need to ask the patient to stand erect, which he may not be able to do. So simple sitting you can take chest X-ray only to rule out pneumoperitoneum. Of course, you can do bedside ultrasound, but in doubtful cases, say pancreatitis, you may have to do CT scan. So simple chest X-ray will exclude all perforations. You can see here pneumoperitoneum on the right side. So crescentic shaped perforation, pneumoperitoneum due to hollow viscous perforation. Already I told you the causes for hollow viscous perforation. Not causes for hollow viscous. The causes for pneumoperitoneum. So maybe hollow viscous perforation like the duodenum, stomach, appendix, intestine, the small intestine, large intestine in that order. And of course external already we have seen due to trauma, penetrating trauma, isn't it? Sometimes there may be gas producing organisms also. And another route is the either per-rectal or per-vaginal route also. So pneumoperitoneum. Of course, iatrogenic, all of you know, due to the laparoscopy. So whatever it is, peritonitis due to perforation will produce half of the emergencies are due to perforation of any hollow viscous viscera. So simple chest X-ray will diagnose half of the cases of peritonitis. So with this crescentic shaped gas shadow. Then of course CT you may need in doubtful cases. So what is the management? So generally what we have to do is immediately institute nil per because you should not further stimulate the bowel. And bowel is also not able to function properly. So no absorption will take place. So immediately nil oral. Then Ryle's tube. Catheter is very important because you have to measure the urinary output. Simple but effective monitoring of the patient is by urinary output measurement. You have to correct vomiting, that is hypovolemia. Electrolytes already told you. Antibiotic is very, very important, particularly combination of cephalosporin and metronidazole. Already I told you about analgesia importance, because if the patient is not taking proper respirations because of pain, there will be all sorts of respiratory complications like simple effusion, pleural effusion can occur, to serious causes like pneumonia. Okay. Then if there is septic shock, you have to support all the organs, vital organs like cardiac, pulmonary, renal, support should be there. And input output chart, CVP measurement, and pulse temperature, all this monitoring is very, very important. So generally it is monitoring and Nilol. Okay, Riles tube is also very important, because as far as possible we should give rest to the bowel, at least initially. Then what is the specific treatment? Of course, specific means for most of the causes of peritonitis, already I told you half of them are due to perforation. So you have to early intervention, particularly in healthy patients, and also those because of post-operative reasons. Immediately you have to open. Whereas in others, you have to be cautious. You have to first bring him to some ideal condition, then only operate. So particularly caution is to be exercised in comorbid conditions. Already I told you about diabetes or COPD or some uh, heart problems, advanced age. So what is the thing we do? Usually we will remove the cause. Suppose it is appendicitis, we will remove appendix. Cholecystitis, remove gallbladder. Whereas divert also. Suppose there is perforation of the colon, do proximal colostomy, like that. But in perforation of the duodenal ulcer, you have to close it. Okay? No removing or diverting. You have to close it. What is important is, more than all these things, it is the peritoneal lavage that is most important in peritonitis. So at least 3 liters, that means 6 half bottles of saline, very, very important. So peritoneal lavage, it can contain dissolved antibiotic also. Though I said immediate surgery for most of the things, sometimes you may have to exercise caution. Don't do any surgery, don't interfere, don't open a case of acute pancreatitis. Similarly, if you know that it is primary peritonitis, particularly in cirrhotic patients, if it is primary peritonitis, then you should not open the abdomen. So exercise some restraint. Though in general it is the early surgical intervention. Then coming to complications of peritonitis. What are the complications? Of course, both local and systemic. Systemic, already I told you about septic shock, SARS, MARS, and even death. So depending upon the site of perforation, death will also increase. Suppose it is duodenal, it may be 10% death. Whereas if it is gastric or ileal, it may be more than that. Right? Then what are the local complications? Paralytic ileus. So already the intestine is tired. So you should not further stimulate it. So there will be paralytic ileus because of inflammation. There may be residual abscess also. After peritonitis, there may be a saphrenic abscess or a pelvic abscess. Then it can spread even to the liver, rarely. But most common complication is adhesions. Adhesions may lead to small bowel obstruction also. So ultimately, it is in systemic. You should you should prevent SARS and MARS, whereas in local, you should prevent adhesions. How? By copious irrigation, right? So that is about this peritonitis. Further varieties we will discuss later in next class. So if you have any doubts, you can ask me. So in the next class, I think we'll go for abscess, peritoneal abscess, right? So any doubts? So the topic is easy or topic is difficult? Only in those two situations you don't have any doubts. If it is easy, you understood everything. If it is difficult, you have not followed. So both may be the causes for no doubts. I presume it is easy topic because already part of it you have already followed in perforated duodenal ulcer. So almost same. Okay, right. Thank you.